You look at something, you should ask yourself, is it congenital or acquired? I had a wonderful consultant that I worked for, physician, he was surgeon this one, inspiration, Gaffer Mimpris. He was very slow, sort of manner of speaking, and we'd stand round the bed and he'd say, just have a look at this. Is it congenital or is it acquired? Is it infective? And so on. Just like that, I think. But you're doing it subliminally. If you're not doing it subliminally, you might have to do it liminally, if I might put it that way. And I'll show you why. Remember this one, though. This is the trip up. This one, I'll show you my trip up shortly. So there are dozens of them down here as well. Now, common things are commonest, they say, but that is a cancer of the tongue. It's a posterior one, and that is undoubtedly a cancer. Really, because they're squamous cell cancers and they have this raised, rolled edge. Why do they have that? It's because they're growing like fury, and as the tumour cells grow, then the multiplying cells on the periphery take up the blood, and the centre bit dies. And that's pretty characteristic of most tumours. But on an epithelial surface, of course, it makes a crater with a raised, rolled, and everted edge. Now that one, she was an elderly lady, but she wasn't greatly bothered about it, and she said it came up just like that yesterday. And I thought, well, is she really sure about that? Because common things are commonest. That looks to me really like a rather unpleasant early cancer. But it isn't. In fact, what that was is, if you stopped and think and went through it, that's actually an infarct. That's a blocked blood vessel causing a little area of necrosis on the tongue. Terribly uncommon, which is probably why I've still got the slide. Now that one was the sort of thing where I had to go right back to the surgical sieve. Can you see it there? Can you see in the midline? There's a rather deep, rather craggy looking thing with a bit of a rolled edge. Painless. And I said to the patient, how long you had that? He said, well, really quite a long time, but I didn't know what it was. Probably didn't want to know what it was. So I thought, well, this is a cancer. So I took a bite of it, biopsy, sent it to the pathologist, who sent back a report saying non-specific chronic inflammatory tissue. I thought, this can't be non-specific chronic inflammatory. Take a bigger biopsy. So I take a bigger one and set it off. Back it comes. Non-specific chronic inflammatory tissue. Now then, I turned to the surgical sieve and thought, I've obviously got this really wrong. Bring the surgical sieve up to the foremost part of my mind, and was it infective? Well, if it's infective, it's chronic, as opposed to acute. Is it TB? And I thought, no, it's not TB, I've seen that. And what's the other one was syphilis. That is a syphilitic gummer. This is tertiary syphilis, and I didn't even think of that. It's really very uncommon, but that is an instance where the surgical sieve, as it were, came to my help. And that is actually all the principles I was going to parade in front of you today. Oh, what's that? Well, when I looked through my collection of slides, I don't think it's what you think it is, actually, first of all. What the hell is it? I don't know. It was in the slide collection. It's not one of my slides. I think it may be due to the result of one of my slightly eccentric colleagues. I think it's part of the gut of a pigeon. But I don't know. And I'm not, oh, you might wonder why. Yes, well, so do I. But I think he's very fond of pigeon guts. It had something to do with the pituitary, and I can't remember what. But anyway, that's what I wanted to say to you, but also just to thank you and wish you all the best for a surgery career. I wouldn't have been anything but a surgeon. It has fantastic rewards, yeah, I enjoyed this. It was a good deal. Go for it. Over to you. That's right. Thank you very much.